Welcome to Nurse 2545, Professional Nursing Concepts 3. On this PowerPoint, we will be going over the respiratory system. You'll find a nice link that is a good review of the anatomy and physiology of the respiratory system. Let's get started. Oxygen is needed for tissues to live. Without oxygen, brain cells die in as little as 5 to 10 minutes. Other tissues, such as musculoskeletal cells, can survive hours without any oxygen. Oxygenation is dependent on gas exchange and perfusion. The need of body tissues for oxygen is balanced with body's gas exchange and perfusion. Our bodies can naturally compensate. For an example, if we exercise or our metabolism increases from illness, such as if your patient has a fever, our oxygen needs will increase. Our bodies must increase activity in perfusion and gas exchange, so we breathe deeper and faster and our heart rate increases. Some of the respiratory illnesses we will discuss and some of the cardiac you have already learned about decrease the body's ability to compensate. For instance, if you have a patient with asthma, they can take in enough oxygen normally, but maybe not be able to adjust or compensate when a greater need for oxygen occurs, such as in an asthma attack. Okay, the functions of the respiratory system. So first we have ventilation. Ventilation is just getting oxygen in and carbon dioxide out. This occurs with expiration and inspiration. Why might ventilation become impaired? Things that impair our ventilation are things like high altitude. So if we have that decrease in high altitude situations, we would have a decrease in oxygen available to us. That air is thinner, so it will impair that ventilation for us. Inflamed nasopharynx, so that inflammation and narrowing of the bronchi. Narrowing of the bronchi you're going to see in patients with your pneumonia and or patients with a exacerbation of their asthma. You also will see a poor ventilation in poor or paralyzed accessory muscles, whether someone's paralyzed or even in the elderly, they just don't have that ability to use those accessory muscles. Next, we have transport. Transport is that carrying of the oxygen on the hemoglobin from the alveoli to cells for metabolism, and they carry that carbon dioxide produced by the metabolism back to the alveoli. So why might transport become impaired? Transport can become impaired due to damage to the alveoli. Causes to the alveoli causing them to become damaged would be diagnosis of like COPD. You also can have a impaired transport because the patient has low hemoglobin, such as a diagnosis of anemia. They could have a decreased production of red blood cells, maybe because they have low iron or they're low on B12, or they have a decreased erythropoietin. Remember, erythropoietin is made by the kidneys, and the kidneys, that stimulates bone marrow to produce that red blood cells. There's an increased loss of red blood cells, if there's an increased loss in red blood cells, such as bleeding, chronic inflammation, or if someone has an autoimmune or malignant disorder, you're definitely going to see an impairment in that transport as well. And then premature destruction of red blood cells. So if they're prematurely being destroyed within the body, things that would cause that would be like a spleen disorder, such as your sickle cell. And then finally we have perfusion, and perfusion is that gas exchange or that ability of the blood to transport oxygen to the cells. This can result in hypoxia if we don't have good perfusion. And then it returns that carbon dioxide, remember, to the alveoli. So why might this perfusion become impaired? This may be caused by a decrease in cardiac output. It can be caused by a thrombi or embolism, narrowing of the vessels, vasoconstriction, and also increase in blood loss. Okay, we're going to do a quick review on anatomy and physiology. First, the upper respiratory tract. That includes the nose that helps warm and humidify the air. We have our sinuses. This helps kind of push out our speech a little bit. They're shock absorbers, and they help decrease the overall weight of the skull. They also help with humidifying that air as well. We have the pharynx or throat, the larynx or voice box, and then the lower tract includes the trachea. The trachea is made up of this stiff ring-like, so it won't collapse under pressure. We have the bronchi and bronchioles, the alveoli where that gas exchange takes place. We have over 300 million alveoli. And then we have the lungs. We have 3 lobes on the right. The right is bigger. It does 65% of the work. 2 lobes on the left. We have the apex just above the clavicle down to the diaphragm. The pleura is that smooth membrane that surrounds the lungs. It lines the thoracic cavity and helps lubricate with a thin layer of fluid, and that just allows those lungs to glide in and out. And then we have the accessory muscles, intercostals, and diaphragm. This also includes the chest muscles, back muscles, and abdominal muscles, and that just helps with that contraction to increase that space. Okay, so oxygen delivery and the oxygen hemoglobin dissociation curve. Um, this is just basically a transportation system. So it's how readily that hemoglobin acquires and releases oxygen molecules into the tissues surrounding it, or the amount of oxygen available and the amount carried by the hemoglobin. So each hemoglobin molecule can carry 4 O2 molecules. So oxygen dissociates with the hemoglobin molecule based on the need for oxygen at the tissue level. So how much oxygen do we need perfusing at that tissue level? Hemoglobin unloads the O2 according to the need. So under normal conditions, 50% of hemoglobin molecules completely dissociate their oxygen molecules. So if we have a greater need for oxygen at a tissue, it will increase that percentage at which the oxygen dissociates or unloads. So what might be a situation where it's going to increase that percentage of unloading? It could be anytime there's an increase in metabolism. Um, if a patient is ill, there's some kind of increase in illness. Um, running, exercising, your body is going to increase that demand. Okay, respiratory changes associated with aging. So respiratory disease is one of the major causes of illness in the elderly. So we're going to review some of these changes in the elderly so you can start to see as to why they're struck with some of these respiratory diseases. So first we'll start with alveoli surface area. That area decreases, and we know that alveoli is the spot where gas exchange occurs. So if we have decreased surface area, um, we're going to have less gas exchange, and they're just less efficient than they would be if they were younger. Um, Increased residual volume in the lungs um, and a decreased vital capacity. So our vital capacity is the greatest amount of air that can be expelled after taking the deepest breath possible. So if you're thinking about that and you're listening to me talk and you're taking your biggest amount of air you can possibly get in and then expelling that, that peaks at age 25. So after age 25, we start seeing a decrease in that vital capacity. So in the elderly or the aging, there's that increased residual volume in the lungs, showing a decrease in vital capacity. Their chest wall becomes stiffer, so it just has that less elastic recoil. Um, their respiratory muscles become weaker. Um, if their respiratory muscles are weaker, they have that decreased ability to cough, or their cough effort is decreased. They have a decreased pulmonary capillary network. So everything at that capillary network, which we'll kind of talk about, everything is just decreased. That network isn't working up as it would if they were younger. Decreased immune response and an increased risk for respiratory infection. They just become just an increased susceptibility that's going on there. There is the chart for greater detail on page 513, 27-1. That'll kind of go into a little more detail on these changes. Okay, pediatric respiratory system anatomy and physiology. The anatomy of the airways are smaller. They have undeveloped cartilage. Comparison of airway structures, their trachea is shorter and smaller and to the right, continues to grow until age 12. For the first 5 months of life, these kiddos have fetal hemoglobin or a shortened survival of red blood cells, so they are anemic. At 6 months of age, they have a decreased hemoglobin from diminished maternal iron stores. So this is why we have that iron fortified formula. And they have less alveolar surface for gas exchange, and they also have narrowing branching of the peripheral airways. Um, that narrowing branching can be easily obstructed by mucus, edema, or foreign objects. Here's a picture that shows um, the difference in diameter of these airways. You can see that 1 millimeter of swelling causes a great deal more obstruction than um, the difference between the adult and the newborn. Uh, the infant and child are more vulnerable to consequences of an upper respiratory infection, enlarged tonsils, adenoids, an allergic reaction, positioning of the head and neck during sleeping, um, small objects being aspirated, all can cause airway obstruction and respiratory distress. Even an increase in crying and anxiety could quickly worsen problems. So just that difference in size. So to continue our variance between adult and pediatric respiratory system. So upper airway differences, infants breathe through their nose. If an infant has an upper respiratory infection, breathing and sucking becomes more difficult. Lower airway differences, the, the growth of alveoli continues until puberty. Diaphragm use for respirations. Um, they use their abdomen to breathe until ages between 5 and 6. Intercostal muscles are not well developed, so retractions are common in a neonate. Retractions are that skin pulling in or tugging around the bones in the chest. So you would see retractions in the neck or above the collarbone, um, typically under the breastbone, between and under the ribs. Um, Immaturity of the respiratory system, surfactant lacking in your premature infants. So remember, surfactant is produced in the alveoli to help prevent atelectasis, or that collapse of that alveoli. So if you have a preemie, they are lacking in that surfactant. And then the other thing I wanted to mention was normal respiratory rates. For a newborn, a normal respiratory rate is between 30 and 60. Between a 6 month and a 12-month-old, respiratory rate is between 24 and 30. 1 to 5-year-old respiratory rate is between 20 and 30. Oh, I'm sorry, 6 to 12-month-old is 24 to 30, and 1 to 5-year-old is 20 to 30, and then 6 to 12-year-old is 12 to It's a relevant patient history. So when a patient comes in, you are going to be gathering their family and personal data. You're going to be assessing things like their smoking, a smoking assessment. So whether they're a current smoker or if they've ever smoked. If they are a current smoker, you're going to want to know the number of cigarettes per day, the duration as far as when did they start smoking, and then packs per year. You want to assess if they use electronic cigarettes or vaping, if they have any drug use, prior or current, if they have any allergies, if they've traveled outside the country, and you're also going to assess their nutritional status. So what does that look like? And then you move on to that respiratory assessment. So first thing is, do they have a cough? A cough is a common sign of lung disease. So not necessarily is it lung disease, but or could it be, but it is a common sign, that persistent cough. You want to assess them for PND, and that's paroxysmal nocturnal dyspnea. And what it is it's severe episodes of dyspnea and a cough at night. So only at night. They really have trouble breathing and they start coughing. So PND. You want to know if they do have a cough. Are they coughing up any blood? Are they having any shortness of breath? Any chest pain? If they are they coughing up any sputum? What does that sputum look like? Have they looked at it? Can they even get it up? And if they do, what color is it? Consistency, all of those things that you've probably seen on your head to toe assessments, but you really want to pay attention to what those look like. Remember, any kind of color in sputum is dead white blood cells, which means that something's potentially going on. And then risk factors. So risk factors, you're going to have non-modifiable risk factors and modifiable risk factors for someone who's at risk for a respiratory disease or diagnosis. So you're non-modifiable. Their age, not modifiable. Gender. Women are at a higher risk for respiratory. Genetics, certain genetics, and race. If they have a family history, air pollution and allergies. So those are your non-modifiables. Modifiables, smoking, number one. We can help get them information to help them quit. Exposure to secondhand smoke is a modifiable. Obesity, sedentary, immobility. When you have somebody who has a sedentary lifestyle, it increases that risk for that atelectasis and pneumonia. If they have exposures to allergens, so something that they can be avoiding. I had a patient once who worked in a factory that he was continuously exposing himself to this. I don't know if it was dust or what it was, but it was causing him to have these asthma attacks, and then he'd come in and full-blown flare, and he was probably allergic to it. But it happened several times before he finally realized that he had to quit his job, which is unfortunate, but it's modifiable, and it was only giving him problems. Exposure to environmental pollutants, exposure to certain recreational hazards, um, occupational hazards, um, and then some med side effects from meds. So specifically ACE inhibitors can cause problems, um, and we can modify those and get that medication switched up, hopefully. facts about smoking. So I'm not going to go through all of these, but I just want to highlight that the benefit of quitting smoking begins to occur within 20 minutes of the last cigarette smoked. Smoking cessation is a priority teaching for all patients every time they come in. Joint Commission requires documentation of smoking assessment and offering of treatment. Smoking cessation meds include Zyban and Chantix. These help decrease cravings and withdrawal symptoms, but may cause mental health issues as well, such as hallucinations or mania. There are some, um, you can offer them a prescription for gum, the patch, while they're in the facility if your facility carries those options. But the main thing to remember is that it needs to be documented per Joint Commission that we've assessed that every single time they come in, and do some teaching with them. Levels of prevention. Primary, we want to promote health and prevent disease. So this is our infection control, smoking cessation, immunizations, preventing post-op complications and avoid risk factors. Secondary, this is screening and early detection. It helps reduce impact of disease that has already occurred. So what does secondary look like? What is an example? So that's your MANTO, avoid asthma triggers, use asthma action plan, and we'll talk about that. And then tertiary, this is all treatments. So this is the soften the impact of an ongoing chronic illness. So management of a long-term existing disease to prevent further negative consequences. So pharmacotherapy, oxygen, airway management, chest physiotherapy, chest tubes, thoracentesis, nutrition therapy, positioning. These are the things that we are doing to just soften the impact of that chronic illness. Now, if we were in class right now, I'd have you take a minute and think about a primary, secondary, and tertiary um, for smoking prevention, cessation, but we'll just talk about those now. So level of prevention regarding smoking. So primary would be education before starting. So 80% of smokers start before the age of 18. So getting the word out and educating younger, start in the schools when they're young. Restrictions on advertising, um, having the parents quit smoking. That's a big one. So if you can stop that role model from role modeling smoking, that will really help um, prevent disease and further disease and promote health. Secondary, ask if they're a tobacco user on every visit. So following that Joint Commission recommendations. Give resources for quitting. Keep asking them, keep encouraging them, keep informing them of all of the complications and what can happen if they continue to smoke. And then tertiary would be medications to help quit, inhalers, smokeless cigarettes, patch, gum. And then there's also, you can recommend a website called whyquit.com, and that can help too with that encouragement. Okay, assessment of nose and sinuses. So first you're going to be looking at that external nose. You're going to be looking for some deformities, such as a septal deviation, where the nose kind of appears in an S shape. You could or may see some tumors. You're going to be looking at the nares for symmetry of size and shape, and then in the nasal cavity. The nasal cavity, you're going to be looking at the color. You're going to be looking for any swelling, drainage, or bleeding. The nasal mucous membranes are redder than the oral. So that's what you want to be looking for, that they're redder than in the oral cavity. If nasal area, if the nasals are pale, engorged, or bluish gray, this may indicate an allergic rhinitis. You also um, want to assess the turbinates. This is the network of bones, vessels, tissues within the nasal passageways that are responsible for warming, humidifying, and filtering the air. You may see nasal polyps. They look pale, kind of a shiny, gelatinous lumps attached to the turbinate. Okay, so assessment of the pharynx, larynx, and trachea. First, you're going to assess the mouth and tongue. You're paying close attention to color, looking at those membranes, checking for any sores within the mouth or around or on the tongue. Posterior pharynx, larynx, that voice box. If you notice that they're hoarse or they don't have quite much of a voice, those are things that you need to be documenting. Checking the neck for symmetry, alignment, paying close attention for masses or swelling, any bruising. If they're using the accessory neck muscles for breathing, that's important to note. And then trachea, you want to palpate for position, mobility, tenderness, and masses. Know that if you have a collapsed lung on one side, that trachea is going to shift. It's going to push away from the affected side. Assessment of the lungs and thorax. So you're going to inspect the thorax with the patient sitting up. You want to observe the chest, comparing one side with the other and front to back. You really want to pay close attention to chest configuration. There's the normal anterior posterior diameter to lateral diameter is 1 to 1.5 or 2. Pediatric variation, normal anterior posterior diameter is 1 to 1 ratio. That's until age 5 to 6. Barrel chested. So you see on the picture in the right corner, the first one on the left is what we would call barrel chested or 1 to 1 ratio. This is due to overinflation of lungs, such as a patient with emphysema. So that barrel chested look is very common in someone with emphysema, or that 1 to 1 ratio. So anterior posterior diameter, a normal is 1 to 1.5 or 1 to 2 in a normal adult. So you're paying attention to respiratory rate and rhythm and symmetry while you're listening to their lungs. You want to, or respiratory rate while you're watching them breathe and counting their respirations. Then you want to pay close attention to the distance between the ribs and the intercostal space. Usually it's 1 finger breath, and it increases with air trapping. So if there's air trapping going on, you're going to have an increase in that intercostal space. You want to pay attention for retractions, again, that where that area sucks inward with the inhale. So remember around those ribs, below the abdomen, around the clavicle area. And then crepitus. Crepitus is air trapping under the skin. It's heard, it can be felt as kind of an abnormal crackling sensation or popping, typically around a trach or a chest tube site, or it can be caused by air sacs abruptly collapsing as lungs fill with fluid. So in your patients with a pneumothorax could potentially have that crepitus sound. We did have some students that were able to have a patient that had that crepitus, and it was quite interesting and loud, so it was surprising. And then there's something called tactile fremitus. This is vibration of the chest wall when we speak. It will decrease if pleural space is filled with air, as in a pneumothorax, and will increase with increased density, such as if a patient has pneumonia and or lung abscesses. And what you do is you listen over the bronchi near the clavicles, between the scapula, kind of in that area, and you listen while that patient says 99, and you'll be able to hear that vibration in the chest wall when they're saying that word 99. Breathing patterns. So normal respiratory rate is 12 to 20. We have dyspnea or difficulty breathing, bradypnea, slow respirations less than 12, tachypnea, fast respirations greater than 20, orthopnea. This is a sensation of breathlessness when the patient is laying down. It's typically relieved by sitting or standing. Hypoventilation, shallow and slow breathing. Kussmaul's respirations. This is, you can describe this as hyperventilation. Rate and depth of breathing increases, resulting in a decrease in PaCO2 levels. This is associated with ketoacidosis. Okay, so ketoacidosis is typically associated with that Kussmaul's. And then we have Cheyenne-Stokes respirations. This is rate and depth of breathing increases and then decrease until apnea occurs. This is associated with heart failure, damage to that respiratory center, and it typically Here are the locations of the lobes of the lungs for your respiratory assessment. Here is a good picture depicting the assessment with the sequence for percussion and auscultation. And remember to always listen to your lungs and do your respiratory assessment on the skin whenever possible. So lung sounds. Bronchial, this is heard over the trachea and it's typically louder. Bronchovesicular, these are heard over the first and second intercostal space below the clavicles anteriorly. This is your main stem bronchi and it's intermediate intensity, so not as intense or as loud as the bronchial. And then vesicular, this is heard around the periphery of the lung fields. It's typically low, soft, and kind of a breezy sound. Adventitious lung sounds. Adventitious lung sounds, so that includes wheezes. Wheezes are caused by narrowing of the airways, so like your asthma, your bronchitis. These are high-pitched, kind of a whistle-like sound, usually heard louder on expiration, but may also be heard on inspiration as well. Rhonchi. Rhonchi are low-pitched wheezes. These are more deep, low-pitched rumbling sounds, kind of like a snoring sound, a rattle, gurgling, or moaning quality. They're heard primarily during expiration, and they're caused by air passing through narrowed tracheobronchial passages, and they're typically associated with mucus, respiratory secretions, or tumor. Um, you're going to see those you're going to see rhonchi with your pneumonias, your cystic fibrosis, or chronic bronchitis. They may clear after coughing or if you suction your patient. Then we have stridor. Stridor is an abnormal, high-pitched, kind of a honking, wheezing sound produced by the turbulent airflow through a partially obstructed airway. Stridor is pretty serious. Something is blocking that larynx if you hear stridor. So these are your cases if someone's choking, you're going to hear that stridor. Severe bronchiolaryngosspasms or croup. That's when you're gonna hear that stridor. Crackles, fine and coarse, aka rails. Sometimes you'll hear people call them rails. This is fluid in the small airways and or in the alveoli, or it could be a delayed opening, like a collapsed alveoli. There's fine crackles. These are high pitched. They're brief, discontinuous popping sounds. So they're not always continuous, but you'll hear that popping sound. Sometimes they're described as wood burning or cellophane being crumbled. That's your fine crackles. Coarse crackles, coarse rattling, crackling sound, louder. They're louder, longer, and lower in pitch than a fine crackle. They're described as a bubbling sound, as when you're pouring water out of a bottle or ripping open Velcro. That's probably the one I hear the most. If you remember that sound of Velcro ripping, That's your coarse crackle. And these coarse crackles are caused by mucus. Pleural friction rub, that's caused by inflamed visceral and parietal pleura rubbing together in the absence of lubricating fluid. So there's not that lubricating fluid there. So you're feeling or you're hearing that rub. It sounds like walking on fresh snow, or if you rub two pieces of leather together, and it occurs mostly with pleurisy. If you really are not as strong on your lung sounds, I strongly recommend you going on YouTube and listening to some of those. And it comes with time when practice as you do your clinical or get into practice once you're an RN. But it does come with practice once you recognize these, but it is good to hear them. And YouTube has some really good videos on lung sounds. Okay, other indicators of respiratory inadequacy. So you want to be assessing skin and mucous membrane changes. You want to be really looking in there, seeing that color, checking those nail beds to see if they're pale. Um, Cyanosis is a very late indicator of hypoxia, so you really want to be looking at that oral cavity and those membranes. General appearance, do they look like they've lost some muscle mass or had a recent weight loss without trying? You'll be able to see those things in their general appearance. What's their activity look like? Do they have an activity intolerance? Can they walk to and from the bathroom without getting short of breath? Or can they still go get their mail, or do they have to stop and take a break? And what about their fingers? So you'll see a picture here of clubbing of the fingers. Normal finger is 160 degrees. Clubbing is at greater than 180. Um, Clubbing is a sign of chronic hypoxic conditions such as your emphysema, cystic fibrosis. Can be a sign of chronic lung infections or malignancy of the lungs. So it's something that we really want to assess as well. Okay, psychosocial assessment. Um, you want to be assessing for stress. Stress can worsen respiratory problems. Um, People with chronic respiratory disease may occur some changes in their life, family roles. They may lose their job because of a chronic disease. And what does that look like financially for their family? Are there some family role changes because they can no longer work, whether it's due to unemployment or disability? How do they deal with that, or how do they cope with that? Is there any social isolation going on? Are we dealing with any depression because they are unable to have that quality of life anymore? Um, so you want to discuss coping mechanisms if you see that that is an issue or problem. You want to get some referrals out for them as well, so they have that access. And then you want to know if there's anything that causes anxiety. Typically, with some respiratory, like your COPDers, sometimes they get more claustrophobic, so they always, it causes them anxiety that they can't breathe because the door is closed. That ability to have that door open might decrease that stress and anxiety. So finding those things out when you admit that patient, those are really going to benefit your patient and benefit you while you're taking care of them as well. And these things that you're gathering, this information, that should be within their care plan too. So okay, so now we'll talk about some diagnostic tests for your patient that comes in on a respiratory patient. So for blood, you're going to see a complete blood count or a CBC. We'll talk about ABGs in a minute, but they could potentially have ABGs drawn as well, depending upon what they look like when they come in. So a CBC, they're looking at red blood cells, hemoglobin, hematocrit, and WBCs. So usually, typically, RBCs and hematocrit kind of mirror each other. So red blood cells, remember, they have the capacity to carry that oxygen. And then hematocrit is the percentage of blood volume composed of red blood cells. So you want to know how much volume of that blood has red blood cells in it, and then how many RBCs are there that has that ability to carry that oxygen. Hemoglobin, remember hemoglobin, that's that protein found inside an RBC or red blood cell. And the number of RBCs, uh, that is, you want to know what the hemoglobin is because you want to know what your capabilities of transporting that O2 to those tissues and then picking up that CO2. So remember that transport capability. And then WBCs. So you're gonna see WBCs because we want to know, is there an increase with infection or inflammation? We're going to see that an increase in WBCs. So we want to rule those things out when a patient comes in with respiratory symptoms. Um, you can use the analogy. Uh, there's the pizza delivery analogy. So if you get confused about these RBCs and the hemoglobin and what's all going on, if you think about oxygen as a pizza, and so red blood cells, the pizza delivery guy, he's the red blood cells, sorry. So the red blood cells are the car. The hemoglobin is the delivery guy, and the pizza is the oxygen. So if you want an analogy that helps you remember that the hemoglobin is inside the red blood cells, the hemoglobin is the delivery guy for the pizza. He's inside the car, the red blood cells, and he's bringing the pizza or the oxygen to the tissues. So that sometimes helps people. I might have botched it a little bit, but hopefully you get the gist of it. Okay, moving on. Diagnostic tests, sputum. So typically they'll want to have a sputum sample sent. Um, not always, not always can someone produce sputum. It's good if they can. It's best to get sputum in the morning, but it's not necessary. So sputum is best in the morning, that first morning sputum, but we would never wait on a sputum test till morning. Does that make sense? So sputum's best in the morning, but if someone's producing and they can get up a deep sputum, we'll take it and send it to the lab. You're going to see standard chest x-rays, CTs and MRIs possibly. They may use contrast. Just remember that if you see an order for a CT with contrast, that it could be nephrotoxic. So you want to check that kidney function and make sure that they're not allergic to iodine or shellfish. They could order a fluoroscopy. So this is kind of an x-ray movie. It shows movement in the lungs. A pulmonary angiography. This visualizes the pulmonary arteries. They could have ordered a ventilation and perfusion scan or a VQ scan. This checks ventilation and perfusion of the lungs, and it can detect a PE. And then you might see skin testing for allergies as well. Okay, so non-invasive diagnostic tests. These include pulse oximetry. Pulse oximetry normal is 95 to 100%. If you have a healthy patient, lower than 91 is a concern, but they might run lower if they have a chronic respiratory condition like our COPDers. But just know that 95 to 100 is normal. You can run a little bit variance on either side. If you have a patient on a pulse oximetry and you are getting some funky readings, first things first is you need to check out the machine. And that's kind of the case with everything. So you want to look at the machine, look and see where the probe is attached. You might want to check other fingers, toes. If they have cold extremities, you're probably not going to get a very good reading. You want to avoid nail polish with these as they won't pick up as well, but definitely try multiple locations with your monitor. Pulse oximetries can be used to qualify for home on the patient and walk them around so they can see how they do without oxygen when they're active. The reason for pulse oximetry 9 times out of 10 is just that it's really readily available. It's quick, it's inexpensive. Our patients can buy them over the counter for not very much money anymore. So that's good, so they can monitor that at home. That might be a recommendation for you if you have a patient that really is concerned about their oxygen level. Okay, and then moving on to capnography. So capnography measures a partial pressure of end-tidal carbon dioxide. Normally is 20 to 40 millimeters of mercury. It just measures that amount of CO2 being exhaled. It's kind of put it in other words. It's more sensitive than a pulse oximetry. We are frequently using capnography more than pulse oximetry for our patients that are on opioids. Capnography tends to detect respiratory depression earlier than a pulse oximeter. With increased partial pressure of end-tidal carbon dioxide, you could have inadequate gas exchange or an increase in cellular metabolism. So things like fever, or if your patient is in acidosis, they're going to show an increase. Decrease would be a poor pulmonary ventilation, so just poor ventilation in general. Things like hyperventilation, if your patient has apnea, or if they have a PE. So that capnography is there as a tool to help detect those things early.